Thanks very much, Joel, for that very kind introduction. As you rightly say, tropical nephropathy is an important disease in our environment. The main factor that differentiates renal disease in the tropics from that in the temperate regions of the world is a much higher frequency with an infectious etiology. However, much of the etiology is idiopathic, and the principles underlying the understanding is similar as well anywhere else in the world. The tropical diseases encompass all diseases that occur solely or principally in the tropics. The term may also be taken to refer to infectious diseases that thrive in hot, humid conditions, such as malaria, leishmaniasis, schistosomiasis, onchocerciasis, lymphatic filariasis, Chagas disease, African trypanosomiasis, and dengue. We will encompass both definitions in this discussion. An overview of parasitic nephropathies, the glomerulonephritis and other related lesions induced by parasites. The magnitude is ill-defined, but is likely responsible for a large proportion of nephritis in the tropical environment. It may account for the much greater prevalence of glomerulonephritis in the tropics than in the United States or in Europe. We can see from this study by Sarala Neka, the renowned nephrologist from Durban, South Africa, who brought up the causes of acute kidney injury in different parts of Africa, North Africa, the West, East, and South Africa. And we note that particularly in sub-Saharan Africa, parasitic causes contribute significantly, as well as bacterial causes. So that in Cameroon, we have diseases like malaria, Cote d'Ivoire, malaria and HIV and toxins were thought to be important. In Nigeria, there is sepsis, obstetric causes and toxins. In Kenya, again, infections are important as a cause of acute kidney injury, as well as the other countries in the region where malaria remains important as a cause of acute kidney injury. Similarly, in Southern Africa, infectious factors are important in the genesis of these of acute kidney injury. We have had different studies by different notable individuals from different parts of Africa on the causes of end-stage renal disease. You note that in purple, we have glomerulonephritis, and in blue, we have pyelonephritis. So Matekole in Ghana came up with that initial pattern of causes of chronic end-stage kidney disease. Akinsola showed that glomerulonephritis is important, while SIDAT in South Africa also showed that glomerulonephritis and pyelonephritis are important, infectious, particularly of infectious etiology. So that both glomerulonephritis and pyelonephritis are important factors in the genesis of chronic kidney disease. In the Kenyan situation, chronic glomerulonephritis is still the most important cause, followed by hypertensive nephrosclerosis, followed by diabetes, then followed by obstructive causes, and lastly is the hereditary causes. So we note that infection is still an important factor in the genesis of both acute and chronic kidney disease. These infections include the bacterial causes, Streptococcus, Pyogenes and Strep viridans, Staph aureus, Pseudomonas aeruginosa. The viral causes, hepatitis C, hepatitis B, HIV, mucormycosis, Candida, dengue fever, cytomegalovirus, polyomavirus, and parvovirus are important. The more infections include Haemophilus influenza, Escherichia coli, Mycobacterium leprae, Mycobacterium tuberculosis, Treponema pallidum, leptospirosis, Proteus, Klebsiella, Brucella, Neisseria, Yersinia, Chlamydia. All these are important causes of kidney disease, particularly acute kidney disease, in the tropics. So we normally get bacterial infections associated with glomerulonephritis. After the infection resolves, there's a latent period of 1 to 4 weeks before the onset of the glomerulonephritis. We get an acute glomerulonephritis in somebody who's otherwise normal. We can also get infection-related glomerulonephritis, where there's an active ongoing infection. These include particularly Staphylococcus aureus associated glomerulonephritis, which is normally IgA dominant. You can have a low-grade persistent bacterial infection, like we can get in shunt nephritis, where we get a staph epidermidis. Infective enteritis can also be associated with this low-grade persistent bacterial infection, often due to Staph aureus or Staph viridans, or can have visceral abscesses formation causing membranoproliferative glomerulonephritis or rapidly progressive glomerulonephritis with crescents. The parasitic nephropathies fall into 3 broad categories. You can have acute renal injury as we get to Plasmodium malaria, leishmaniasis, or babesiosis. You can have physical invasion of the urinary tract, like we get with schistosoma, like with filaria, with Echinococcus granulosus. We can have renal injury caused by the host parasite immunological interaction, like again, like with Plasmodium, leishmaniasis, filaria, toxoplasmosis, trypanosomiasis, trichinella, spiralis, etc. So these interactions are important. A disease like cholera can cause a hemodynamic perturbation, principally. Disease like scabies can cause principally an immune response. Antibiotics will cause toxic nephropathies, like with the amikacin and non-steroidals, etc. While with the typhoid fever, we mostly get tissue invasion. But there are combinations, so that in a disease like malaria, we can have both combination of hemodynamic perturbation and immune response. Kala-Azar can have both toxic therapies and immune response. Tuberculosis can have both tissue invasion and toxic therapies. So we can have a combination of factors in the pathogenesis of these infections. The immunology of the parasitic nephropathies, we can have host-parasite interactions, parasite recognition by host MHC, so that parasite antigens and metabolic antigens, mostly excretory and secretory products, are being important. We can have formation of antibodies or formation of immune complexes. This could be immune complexes in circulation, the circulating immune complexes, like with schistosoma mansoni, or could be in situ formation of the immune complexes in the kidneys, causing the damage. We can have lymphocyte activation and clonal expansion with release of mediators of inflammation. We can have damage to resident cells of the kidneys as in the pathogenesis. We can also have evasive mechanisms so that we have antigen variability within the same or successive generations. The antigenic variability that is famous for trypanosomiasis and Plasmodium. We can also have blinding host cells to parasites, particularly with the blood groups H and the H antigen. Can also have the downregulation of monocyte response, like in leishmaniasis, or a situation of antigen excess, like in schistosomiasis, or induction of suppressor T cell clones, again in the setting of schistosomiasis. So these are evasive mechanisms that contribute to the development of the nephropathies. The clinical manifestations include asymptomatic proteinuria, acute tubular interstitial nephritis, acute glomerulonephritis, chronic glomerulonephritis, renal failure, which can be both acute and chronic. The parasitic nephropathies share some characteristics. There could be regression of acute insults or lesions, so that there is full recovery after the episode of the parasitic infection nephropathy. We can have a relentless progression to end-stage renal disease in 3 to 8 years for severe disease. We can also have poor response to steroids and immunosuppressants, particularly with these chronic situations. And when you treat the initiating parasitic infection, oftentimes there's no effect on the progression of the nephropathy. So the only positive result is where we have an acute insult with rapid regression and total recovery. The treatment of parasitic infections is beneficial in acute cases, but in chronic cases, the treatment of parasitic infections is of limited benefit. Steroids, immunosuppressive drugs like cyclophosphamide and azathioprine have limited benefits. So this is the spectrum of parasitic infections, and Africa is heavily involved with Schistosoma hematobium and Masoni being in the area shown. Can have Echinococcus granulosus is also prevalent in this. Quartan malaria is mostly in West Africa and Uganda, although the cases are diminishing rapidly over the years, so that very few cases have been shown recently, probably because of the effect of antimalarials. Plasmodium falciparum, we can see in Southeast Asia, in Africa, very important, and in South America. These parasitic infections, of course, affect the whole world, but Africa is particularly affected, as seen in that diagram. So we have a spectrum of renal pathologies in tropical nephropathies. So Salmonella will mostly give you a membranoproliferative glomerulonephritis or acute interstitial nephritis. Shigella can also give you glomerulonephritis. Leptospira, similarly, will give you acute interstitial nephritis. Melioidosis. Cholera is mostly acute interstitial nephritis, while the scrub typhus, diphtheria, and tuberculosis are also shown in their effects of the kidney in terms of glomerulonephritis, the vasculitis, and acute interstitial nephritis. These are diseases that we still commonly see in our setup when we get attacks of cholera, the episodes of tetanus. Leptospiras is still common in the sugarcane plantations. Tuberculosis, of course, is still a very common disease in our environment. So these are diseases that need to be investigated and established appropriately, so that where early cure is, early treatment is implemented, cure can be obtained. The clinical manifestations vary, so that we can have abdominal sediment in the urine, can have proteinuria, acute renal failure, acute kidney injury, chronic kidney disease, hemolytic uremic syndrome, hemolysis, disseminated intravascular coagulation, jaundice. So they occur in different diseases as shown. Example is in typhoid fever with salmonellosis. You can have abdominal sediment, you can have proteinuria, you can have acute kidney injury, hemolysis, all can happen. With leptospirosis, we mostly get abdominal sediment, can also have proteinuria, acute kidney injury. With leprosy at the bottom, we can have abdominal sediment, proteinuria, chronic kidney disease, and acute kidney injury can occur as a result. So let's not be blind to these diseases that we have learned over the years in the medical school, but we often not forget to investigate and make appropriate diagnosis, particularly where they are common. Pathogenic mechanisms include hypovolemia, like you get with cholera, can also get with shigellosis, can have rhabdomyolysis, as you get again with cholera, or salmonellosis, as well as shigellosis. Can have disseminated intravascular coagulation, contributing to the kidney involvement, again with salmonellosis, shigellosis, and leptospirosis. In diseases like tetanus, hypovolemia is important, as well as the monokines being important in the pathogenesis. The renal involvement in malaria is important because it is still a disease that we see frequently, particularly when non-immunes or partially immunes come from Nairobi and go to the western Kenya or to the coast and come back with malaria, and because of their partial immunity, they get very severe disease in December and over Easter. So we get acute renal disease, acute tubular necrosis, can have acute interstitial disease, or an exudative glomerulonephritis due to Plasmodium falciparum. The chronic kidney disease is mostly mesangiocapillary glomerulonephritis due to Plasmodium malariae, but this is very uncommon these days. Malarial-associated renal failure, or MAF, is common in the tropics, mostly due to Plasmodium falciparum. It affects the renal tubules and causes acute intravascular hemolysis, particularly with heavy parasitic infection. The global incidence of malaria is about 400 million cases annually. The annual mortality, one child dies every 30 seconds. The annual incidence in the UK increased from 1,500 in 1977 to 2,500 in 1996, mostly due to the effect of the planes transporting malaria to the temperate lands. This is a global distribution of malaria, as we are all familiar with. I can also have intravascular hemolysis due to malarial infection, antimalarial drugs, G6PD deficiency, which we do have in our environment, or quinine, phosphates, or pyrimethamines. The drugs are normally the cause of severe hemolysis as part of the black water fever syndrome, in which there is normally scanty parasitemia, and there's massive hemolysis as a reaction to these drugs. So malarial renal failure is common because of kidney failure with heavy parasitemia. 1 to 4% develop acute kidney injury. 60% develop in malignant malaria, develop acute kidney injury. There's usually an oliguric acute kidney injury in catabolic, of the catabolic variety, often associated with cholestatic jaundice, rarely hepatocellular, and lasts a few days to several weeks. This is the molecular aspects with the rosetting, particularly with blood group antigens. We have rolling of the endothelium, we have endothelial activation, we have endothelial site adherence, particularly with receptors CD3, CD36, CSA, so that we get vascular occlusion as a consequence of all these activities. And this is important in the genesis of acute kidney injury when you're dealing with the capillaries in the kidney. The associated features are hematological, hemolytic anemia, DIC, can have cerebral features with common neurological motor deficits as part of cerebral malaria, hepatic, jaundice, circulatory, peripheral pooling with low cardiac output and shock, acute respiratory distress syndrome, rhabdomyolysis, and metabolic, like with lactic acidosis, hypoglycemia, hyponatremia, hypocalcemia, and very dangerous situations. And particularly when all these things occur in constellation, the chances of the patient surviving becomes very slim. So this can be a very dangerous disease. So early treatment is very, very important indeed. Early effective treatment is hypobilirubinemia is important almost in all cases of acute kidney injury. We have unconjugated bilirubin, which correlates to the parasite load. The conjugated element indicates cholestasis. So the cholestatic jaundice is important, and oftentimes when it exists, the advent of acute kidney injury is almost invariable. The true malarial hepatitis is a rare event. Hyponatremia does occur commonly. Occurs in 12 to 55% of cases. Can be due to internal dilution, intracellular sodium efflux, due to ATPase inhibition. urinary sodium wasting, and there is no significant effect of increased antidiuretic hormone. The treatment, antimalarial therapy, is important. Artemisinin derivatives are potent. They inhibit adherence properties and reduce parasite count remarkably, and they are the drugs of choice. Quinine used to be important, but is less used nowadays. We should use normal doses of quinine in the first 24 to 48 hours, and thereafter reduce the dose to 10 milligrams per kilogram body weight, 12 hourly, or 24 hourly for 7 days. Occasionally, in like extreme situations, exchange transfusion may be warranted. The dialysis is important in hypercatabolic states, and this should be done early. Early dialysis in these patients is important because oftentimes, if you delay, when the patient changes condition and becomes hypotensive and sick, and you end up catching a tail which is rapidly slipping away from your hand, and the patient dies. So in this case, early dialysis is clearly important, particularly in the hypercatabolic situation when there's a rapid rate of rise of creatinine, urea, rapid rate of rise of potassium, and oliguria. Don't waste time in these situations. Hemodialysis or hemofiltration, hemodiafiltration, CRRT are options, but in the very sick patients, CRRT is a preferred mode of therapy. Peritoneal dialysis is less preferable due to impaired peritoneal microcirculation, parasitized erythrocytes, vasoconstriction, reduced solute transport, but there's improved efficiency as parasitemia decreases. Continuous peritoneal dialysis is beneficial. Many studies, particularly in the earlier years, early decades, in Vietnam and Southeast Asia, that peritoneal dialysis was demonstrated to be very effective. So don't ignore it when you're in a situation where hemodialysis is not available. It will be life-saving in these situations. Particularly when you have multi-organ failure with cerebral malaria, hemodynamic shock, respiratory distress, malarial renal failure, hematological disorders, DIC, digestive disorders, oftentimes you are unable to escape, and mortality is almost unbearable. So prophylactic for the non-immune or partially immune, when they go to the malarial endemic areas, then become extremely important and is not for discussion. Poor prognosis with prolonged disease duration, with severe acute kidney injury, which is persistent, with oliguria and anuria, cerebral malaria, hyperbilirubinemia, and DIC associated with the poor prognosis. Cotton malaria, circumstantial clinical epidemiological evidence and an experimental work had shown that it exists, but unexplained various pathologies in different countries. In Uganda, we mostly got proliferative glomerulonephritis. In Nigeria, we got membranous glomerulonephritis. In South Africa, we got focal segmental glomerulosclerosis. So this was an area of a bit of uncertainty. No recent data on cotton malaria. All recent publications report the disappearance of this entity from around 19 African countries. Could be improved in nutritional status or improved availability of antimalarial drugs could be factors, as shown by Basum in that presentation. These are the pathologies as shown for cotton malaria. So the challenges for malarial renal failure: early diagnosis and treatment of malaria is important. Prophylaxis for non-immunes and semi-immunes, advised rituaries and internal movements of nationals, widespread use of peritoneal dialysis, like in the Vietnam studies, spread out of hemodialysis facilities, like we have in the Kenyan program, where all the counties have facilities for dialysis, and which formed a NIDAS and enables expansion of dialysis facilities in all the parts of Kenya. Malarial control strategies, bed nets, etc., and studies to resolve the debate on cotton malaria, which I think the postulates are as mentioned. A little on schistosomal nephropathy. So this is basically the life cycle of the schistosoma, schistosoma mansoni, and from man to the water to the biampilaria and the Saccharia back to man. The cycle for hematobium, basically we have oviposition, release of soluble egg antigens, granulomatous reaction onto fibrous ascitic patches with chronic cystitis, and possibility of squamous cell carcinoma arising as a result in schistosoma hematobium. So this is main pathogenic pathways: release of soluble egg antigen in the portal tract and the colloidal mucosa, granulomatous reaction, fibrosis. In the intestine, we have portal tract portal fibrosis and cirrhosis, effect of the mesentery. We have eggs in circulation and antibody-antigen complexes forming, and the kidneys we form glomerular deposits as main pathogenic pathways. So the antigens are rather ill-defined. We have soluble egg antigen, the adult worm antigen, the tegument antigen, and schistosomal cathodic and anodic antigens in the glomeruli. The antibodies, basically tegument or gut of the adult worm, or polysaccharide antigen, or called the gut antigen, or polysaccharide B cell activation, or can have circulating immune complexes of the schistosome with antibody and antigen complexes. We can also have host susceptibility based on the HLA B5, mostly get mansoni and intestinal polyposis. A1 and B5, we get hepatic fibrosis, and A28, the susceptibility to glomerular disease has also been noted in various studies. The glomerulonephritis is reported particularly in association with salmonella infection. Hematobium and salmonella is a bad combination, usually leading to mesangial proliferative glomerulonephritis. With mansoni, occurs in association with hepatosplenic schistosomiasis. Usually there's a heavy worm load, there's proteinuria, which is poorly selective. Hypertension is seen in 50% of cases, and circulating immune complexes are present with C3 in the biopsy specimen. Other forms of glomerulonephritis: mesangial-proliferative, mesangiocapillary glomerulonephritis, which is the most common, focal sclerosis, membranous glomerulonephritis, diffuse proliferative and cholestatic transformation, and amyloidosis. Bit of the pathogenesis of schistosomal amyloidosis. So this is the histological classification. Indeed, it originated from Egypt, and it was actually called the Afran classification of schistosoma mansoni. Class 1 is mesangial proliferative glomerulonephritis with minimal or focal or diffuse manifestations. Class 2 is diffuse exudative or endocapillary glomerulonephritis. Class 3 is mesangiocapillary glomerulonephritis. Class 4 is focal and segmental glomerulosclerosis. Class 5 is in the presence of amyloidosis. And class 6 is cryoglobulonemic glomerulonephritis, usually in association with hepatitis C infection. So this is Afran classification. Some of the pathologies showing mesangial proliferative glomerulonephritis and acute exudative glomerulonephritis, mesangiocapillary glomerulonephritis, focal segmental, and amyloid, as seen with the Congo red staining. And the treatment: anti-schistosomal agents, oxaliplatin, praziquantel, niribazole, metronidazole in types 1 and 2 diseases. Concomitant infection must be treated, e.g. salmonellosis and hepatitis C virus, for which we now have good treatment. Anti-schistosomal agents are not generally effective. Immunosuppressants, cyclosporin, cyclophosphamide, remission have been reported in a third of cases, but is again not very commonly used. The diagnosis, you do stool and urine tests, but they're rarely useful. Glomerulopathies is a late event. Serology, there's fast ELISA, there's Hammers, and gut antigen. Rectal biopsy is important and must be done as a side lab. Liver biopsy, renal biopsy, and regular screening and antiparasitic treatment are with variable responses. So the challenge is early diagnosis and treatment in endemic areas, mass screening, stool and urine tests, enhanced serologic diagnosis for late disease, and further research in diagnostic modalities. And of course, those of you who practice in Kenya know well of the massive esophageal bleeding that occurs mostly from the Machakos area. So this is an area that still needs heavy investments to fully overcome in our environment. So infection-related kidney disease can be a challenging diagnosis due to variable patterns of injury and different pathogenesis. With the emergence of new infections and the reemergence of old ones with different strains, will continue to be one step behind. Infections should be included in the differential diagnosis of acute glomerulonephritis, membranoproliferative glomerulonephritis, and explain acute kidney injury, and should be ruled fast in cases of small vessel vasculitis. Further challenges, hepatitis B vaccination is important. Reduction of hepatitis C in dialysis unit, appropriate use of antibiotics to prevent post-infectious glomerulonephritis, and enhanced food hygiene for diarrheal diseases, increased facilities for renal replacement therapy are all important. I must mention that the COVID situation presents a totally new entity for which we probably don't have time. That is a major cause of renal disease, an infectious cause, which all of us must be thoroughly conversant with in this serious situation of COVID. Thank you very much.
Thank you, Dr. Were. It's quite a comprehensive kind of presentation. You have quite covered a large ground as far as tropical nephropathy is concerned. And I think it's a very important aspect because we tend to forget about it. We don't think about it when we with some of these patients. Thank you for your especially emphasis on the various problems that arise because of malaria. We seem to be forgetting malaria, that malaria is still a big problem in this country. It causes kidney disease. And with a detailed emphasis on also schizosoma, forms of nephropathy, and the various kinds. Thank you so much. I think this is a very detailed kind of presentation. I would want to request for more questions to come, and maybe before I want to request members to come up with questions and to Dr. Were for this very important topic. I wanted to actually, I'm very happy about like what you have just said, a few questions where you have just concluded by saying, especially infection-related kidney diseases are very difficult case, not only difficult in terms of making a diagnosis, but actually to find. I wanted my first question to you is, I've often come across a patient, say a 20 to 25-year-old, and as a nephrologist, you get this patient in end-stage kidney disease. And when you try to sort of take a history to find out what could have led into the end-stage kidney disease, apart from you get a patient in end-stage kidney disease with hypertension. I wanted you to just, how do you go about this kind of young person, no history of chronic, say chronic ulcer, chronic leg ulcers, for instance, hepatitis B and hepatitis C negative, no diabetic, no, how do you go about looking at these difficult cases, and how do you come up, and if they ask you, well, the biggest question the relatives would ask, what is the cause of this problem? How did this patient, and if you look, the only thing that you can know that this seems to have been an advancing chronic glomerulonephritis gradually. How do you go about investigating these patients with limited resources, say in some parts of this country, and how would you answer relatives who ask you, what is the cause of a young man with no non-communicable diseases going into end-stage kidney disease?
Yes, that's a good question, Joel. Oftentimes, by the time somebody is in end-stage renal disease, it's difficult to distinguish exactly what caused it. But as we say, a lot of our glomerulonephritis is post-infectious. Of course, you can investigate for other causes of glomerulonephritis, issues of vasculitis, issues of connective tissue disease, issues of the different many causes of glomerulopathies. Oftentimes, they'll also be associated with hypertension. There could be a proteinuria, but by the time you're in end-stage renal disease, that proteinuria will also have subsided significantly. So it's mostly speculative, uh, but definitely studies are important. Indeed, in Yaki, we are, since biopsies is not very easy in chronic kidney disease, particularly in end stage, because of the risks of bleeding, etc. The possibility of postmortem biopsies is being followed up by Dr. Walong in the Department of Pathology at Nairobi University. And I think that will give us a lot of information on possible factors that could have contributed to the development of the glomerulonephritis. But oftentimes, by the time you reach end stage, it's very difficult to distinguish all these different properties. But post-infectious glomerulonephritis is an important entity and is contributes to a lot of the diseases, of the renal diseases that we get in our environment.
Thank you, Dr. Were. I want to request, just before we allow the next chair for the next session, like Dr. Wala should be coming in by now. Is there any other person with a question to Dr. Were on this very important topic? You can write your question or you can unmute yourself and ask a question, please, anybody?
Dr. Kiapi, maybe I can ask a question.
Yes, Dr. Wala, yes.
Dr. Were, thank you for a nice presentation. Now that we live in the tropics, I'm often faced with the same scenario like Dr. Kiapi's. A patient with suspected or confirmed glomerular disease, bearing in mind 70 to 80% of glomerular diseases, glomerulopathies are idiopathic. I usually screen by testing for hepatitis B, C, HIV. Maybe I can extend to VDRL. Is there any other tropical disease that I should screen for? Now that you have presented so many diseases that can cause the glomerulopathies.
It all depends on your environment. Like I've mentioned, the Machakos region with lots and lots of masonite causing the periportal fibrosis. When you have hepatosplenomegaly schistosomiasis, the possibility of renal involvement becomes very important because the gut antigens will have bypassed the varices and gone directly to the kidneys to cause the nephropathy. So schistosome is important, both the hematobium and masonite, because when you combine masonite with hepatitis C, hematobium with salmonellosis is an important cause of renal disease. Similarly, hepatitis C combination is important. So the list of diseases that we've mentioned, it all depends on the epidemiology of where you are. Like in Egypt, if Professor Nasrallah could tell us, that has always been the kingdom of the schistosomiasis. So it's a place that is owned by both the schistosome and human beings. It's really full of disease there. He could have made some addition to that. And indeed, a lot of the nephropathies is because of the masonite. So it is all epidemiological factors that make you think more of one or the other. If, in my early rotation in public health, the Western Kenya, leprosy was very important, and that's if you're in that environment, then you should seriously consider it as a cause. Syphilis, etc. So I think this is epidemiology of the question of where have you been is extremely important in medicine and tells you exactly where to direct your investigations and whatever you have. But as we said, by the time you reach end-stage renal disease, it's difficult to distinguish exactly what has caused the problem earlier.
I wanted to add one to Dr. Wala, as you almost, I let you take the next session, that one of the areas I found in some of the patients, found patients with probably, for example, cases who have had chronic osteomyelitis for many years, especially as they transit from late childhood to early adulthood. You get some of them, they have been in the process advancing from chronic glomerulonephritis to end-stage kidney disease. I've also found cases with chronic leg ulcers, which used to be called the tropical ulcers. Again, you would wonder, is it the infection? Is it the post-streptococcal skin infection? Is it the Staph aureus? That a number of them seems to advance to go to chronic kidney end stage. I found also cases like patients who have had burns and with prolonged infections, say either scalp burns or any skin burns with atrophic scars. This seems to be easy to get the diagnosis. I have no issues in, you can be able to say this is either a post-infectious going to chronic glomerulonephritis, but you have, just as what we are aware as presented, you get a case, and I'm sure you have gotten a young man, and you look for a part, and you will be able to rule out tonsillitis. Actually, you may be able to say that the patient had tonsillitis in early childhood, they regressed, but went into end-stage kidney disease. That's what I found some of those very difficult cases.